Welcome everyone to today's webinar, Dissolving Medication Access Barriers. I am Andrea Park with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dustin Eubanks is the Director of Business Development at CoverMyMeds. With over 10 years of healthcare experience, he helped to create and launch the largest point-of-prescribing real-time benefit check solutions in the market. His focus at CoverMyMeds is on connecting all stakeholders to find solutions which best serve the patient. At this time, I am pleased to turn the floor over to Dustin to begin today's presentation.
Thanks, Andrea. I appreciate the introduction. As she said, I lead our prescribing decision support technology team here at CoverMyMeds, and really excited to take the time to kind of share the information that I've learned over the last couple of years as kind of building out this solution, and it's refreshing to share it with people that are trying to solve a similar issue. So I appreciate you taking the time, and let's go ahead and dig in. So for today, we're gonna cover a few key issues here. We're going to talk about medication access barriers in the market today, solutions to address these barriers, and how health systems and high volume practices are implementing solutions to solve it. This is probably going to be the most crucial part to what I'm going to dig into, as it's been the most educational piece of my journey over the last couple of years, as we learn how people really are implementing these solutions and using them live in the market to solve these problems. So we also want to talk about how we use these offerings to work through point of prescribing for high-cost drugs, which is probably where these solutions matter the most, and then what information really goes into decision-making and shared decision-making. So let's start with the current access barriers. So as we kind of look at the entire list of what we think about, we definitely dig into prior authorization, which is probably where we first tried to address this issue, and then shifting more towards the price transparency and benefit transparency at the point of prescribing into the care team, and then the communication methods between those, and then ultimately what's most important is as we kind of think about how we get to know the patient and how all this overlays. So one of the things that's really important to us is we need all the data and all the inputs in order to overlay it to the patient. So you have to forgive my cheesy tax season analogy, but think about a patient at the beginning of the year. They get their taxes and then they want to update their W-4, right? They need to know how many dependents they have, how much money they saved. They need a lot of different inputs in order to make sure that they kind of break even how they want to at the end of the year and get the outcome they want. And that's a lot how price transparency and med access works for patients too. We need all the inputs in order to make an informed decision and make the right guidance, especially if we're going to ask care team members to really invite the patient for the first time ever into the decision-making process. So we really want to think about it from that perspective, right? We need everything in order to be a good advocate and to match the right answer to the right patient based upon what they need. So to get things started, we'll talk about the prior authorization piece first, right? It's well documented that this is one of the biggest frustrations for prescribers, where 86% of patients are feeling the burden to be high, and almost 90% are feeling it to just continuously increase, right? And one of the things that we're seeing as a trend is that almost 72% of the prior authorization work has actually shifted to medical assistants, nurses, and PA specialists, which wasn't the case a few years ago. And it's a direct response to the clinical complexity of these prior authorizations matched with the amount of burden that it takes to get the patient on therapy. So we want to make sure that we're very cognizant of how we empower the entire care team to address this barrier. So thinking about the prior authorization as a barrier, we're definitely seeing, 1 in 4 providers are digging in, doing about 10 PAs a week. But then we talk about specialties or high volume prescribers where they're doing as many as 20, right? These are the prescribers that really know their drug classes, the efficacy, and the barriers associated with them, that really want to dig in and make sure they're matching the patient to the right therapy, whereas price and PA is only one indication that they want to think through as they're making these calls. And then we also know that patients are seeing this as a big delay in therapy, and we're seeing that patients are getting abandoned, and we're seeing a ton of prescriptions impacted annually due to this challenge. So at Cover My Meds, we spent a lot of time reaching out to these teams and helping them to navigate this process. And as we talk about a gastro nurse that we've commonly worked with to navigate this process, she's really feeling like, as she's stepping in and taking on the burden from her doctor and making sure that her doctor has the opportunity that she needs to spend time with patients, the burden is shifting, right? And they're asking this gastro nurse to become an expert in this and to really become a PA guru to help navigate this process. But she would feel more like a ward clerk than a traditional nurse that's focusing on the FaceTime, right? And that's something that we want to address. We want to dig in as we talk about these new teams that are getting spun up to help dissolve these barriers. Another issue that's directly related is the lack of price and benefit transaction, right? So imagine that ward nurse where where she feels like a ward nurse that her doctor, she's prescribing what she needs, what she thinks is best, but if the nurse downstream doesn't know that was an informed decision or an intentional decision, it can sometimes make them second guess, why are they doing it? Why does it matter? Did they know that there was a therapeutic alternative or a different path to access? Which is why we need to link this and make it a shared decision tool and make sure that every step of the process and every care team member knows that these were intentional decisions. And we also know that we need to increase the benefit response rate in order to make this work, right? So if we want to be able to say, no, I really want to do this PA, and I want that person downstream on the care team to pick it up and go ahead and do that, then we want to make sure that they have the information to make that decision. And that's a critical piece to make sure that there's trust between those two care members. So one of the things we see is you have to increase the benefit response rate. And one of the challenges that we see to doing that is that it's still a bit of a fragmented market. There's not really a single place to go get all this data. And we also see that not every plan has opted in through real-time benefit check through their PBM, which directly can impact how often a solution can respond. And I think it goes without saying that formulary benefit has done some injustice to kind of the market by not making patient-centered decisions, not knowing plan level information, and kind of created a little bit of a distrust and a rift between the prescriber, the centralized team, and the pharmacist and patient who are trying to make shared decision making. And why this matters is that formulary benefit is commonly shared real estate with real-time benefit check. So when real-time benefit check doesn't respond with benefit information, we're falling back to what wasn't trusted in the first place. And I wouldn't say that we're really driving prescriber trust in new habits and we're really improving the process. So we definitely want to dig in to figure out how we flip this model on its head to say we need more true benefit responses over F and B to get prescribers to really step into this process and to make the rest of the care team feel good about these decisions. So what's important is maybe there are alternative ways to get at this data or to get at this information than thinking about the traditional real-time benefit check models that are out there in the space. What happens when there is this disconnect between the care team is it means that patients are still falling through the cracks, right? So if providers are spending more time than ever navigating health insurance issues, and it's pulling them away from FaceTime with the patients, then that directly means that the nurse has to step in and fill that void for him or her. And that's creating a challenge, right? It's causing another bandwidth issue. It's just shifting a bandwidth issue to somebody who really wants to step in and help. But as we dig forward, it means that even more patients are falling through the crack and being addressed by the pharmacy, right? So what's happening is that there are people on the care team that want to insert themselves to advocate and help the patient, but they don't have all the information, or they don't have all the choices available in order to advocate across the patient. So some patients are getting left behind. And meanwhile, we know that it's important to highlight that there are certainly patients that would step up and advocate for themselves. They don't have access to these choices either. They don't understand some of the implications that they're making and some of the challenges that they need to dig into in order to navigate this process, right? So we're really asking patients for the first time ever to understand very complex processes, and everybody who wants to and can help them is being bogged down by the entire process. So we really want to think about how we want to link these strategies to make sure that every patient is met on their terms and educated on their choices by the most appropriate person on the team. So not to make things any simpler, but we also have we need to focus on social determinants of health when we think about matching the right choices to the right patient, right? So if we think back to the cheesy W4 analogy, it's really hard to take what plan are you on? Are you high deductible? Are you low income? Have you met that deductible yet? Do you want to meet that for the year? Where are you at in the process? And then also taking it and layering it against who the patient is, right? Where are they at on their rent, right? Even if you want to meet their deductible, can you afford to use your benefit, or are you looking for better options in the meantime to just allow you to stay afloat on a monthly basis? So we really want to take this and layer it onto the next level to really inform shared decision making and making sure we're matching the right solutions to the patient and allowing the care team to step up and advocate. So let's talk about how we want to manage some of these. One of the things that we think is most important is we need to bring in the rest of the care team. And this is really a lesson that we have learned as we've thought about the health systems, the specialties, and the high volume prescribers. This is how they see the care team, right? They're just trying to drive adherence. They're just trying to get the patient on therapy. So if we want to win their trust as a prescriber in order to step in and help them quarterback the care process, then we need to bring in the same care team that they see and they utilize. So we want to make sure that the payer and PBM has a seat at the table. They're a critical input as to where the patient is in their benefit and the process of meeting their deductible, what the choices are, what's on formulary, what's not. These are extremely critical decisions, inputs into a decision. We also know that health systems and specialty practices will commonly invite life science to the table to help address access barriers around affordability for the patients that need it. When they've matched the patient to the most efficacious drug for them, who can help me get that patient on therapy? So we definitely see them as something that they want to invite to the table. And then we also see that pharmacy is kind of the last mile, right? Pharmacy needs to know that these were intended decisions, what the process was, and that we can stand behind these decisions along the way, and really would feel good about knowing that the patient's coming in with good expectations for the first time ever. And meanwhile, we want the patient to be in the center of all this, right? All this is about driving their adherence and reducing their access barriers and making sure that they've got a quick speed to therapy. So we kind of see this as an overlay into the patient journey, right? If we talk about a sick patient who's kind of discovering an illness, that's getting diagnosed, getting access to medications, and then needs to stay adherent on the drugs to get the outcomes that they need. And really where we see that these solutions live is squarely between the diagnosis and access stage, right? We want to go ahead and step in and see how we can make sure this process is navigated. And when we take inventory of who's involved in that process, we see 4 key stakeholders on the care team. We see the prescriber, we see the nurse and administrative staff that help step in and fill the gaps and advocate for the patient when there's really a lot of details and challenges to navigate. the patient themselves or the patient's care teams or caregivers that are associated with them, and ultimately the pharmacist too, right? Who has most commonly been the one that stepped in and kind of challenged what we need to do in order to get the patient on therapy. So when we think about how we would empower the entire care team to step into price transparency and choices in order to reduce these access barriers, we really think about how we might need to hone the system to what the expectation is, right? So if we think about a prescriber who really just wants a simple and actionable user interface so that she can make a quick and informed decision without being flooded with too many choices and too much information, right? If we talk about the nurse and administrative staff, we think it's important to note that this is probably the best team to go through more complex issues. Imagine, hey, do you want to drive an extra 5 miles to go to Costco versus another pharmacy? We think that's the nurse that's most suited to be the person on the care team to help dig into those intricacies and really step up when they've notified that a patient or a prescriber has found an issue with a patient who has barrier issues. And there are also patients that really want the robust tool set, right, that would step up and advocate for themselves and say, no, I got it. I know my choices. I want to navigate it and find my own way there. And if we empower them, we can also pull the patients out of the prescriber and nurse admin funnel that are using bandwidth as well. And then we want the pharmacist and the tech to have the choices to the options as well, right? So imagine that a patient didn't get the guidance that they needed at either the stops above. This is the last person to step in and talk about alternatives and choices and cost options to really make sure that they stay on therapy and that they're not surprised by that encounter when they're actually looking to pick up the medication. So the best place to start is thinking about the optimization of EPA, right? That seems to be one of the biggest squeaky wheels that we see in the market today. And we see that prescribers are being notified by the patient and the pharmacy more than anybody that a prior authorization is needed. And what that tells us is that real-time benefit check isn't hitting the scale we need yet in order to help them make that informed decision to avoid that surprise later. And why this matters is that we know from the data that we see that a patient can increase their speed to therapy by 13 days if we move them from a pharmacy-initiated prior authorization to a prescriber or provider-initiated prior authorization. Another interesting stat that we've seen through our own real-time benefit check solution is that when we put real-time benefit check on the front end and true EPA on the back end, we see a 23% shift from pharmacy-initiated to provider-initiated. So the solutions are working, right? We are seeing that prescribers are creating what I would call more of an intentional PA than ever and willing to step up and ask their team and resources to proactively solve the issue before the patient even gets to the pharmacy. So we want to talk about how we can solve the prior authorization solution, right? We know that there are still PAs that go through fax and phone that cause further delay in the process. So one of the things that we think is important is bundling true electronic prior authorization to a plan on a PBM. We want to bundle that with real-time benefit check, with the benefit information on the front end, and then we want to empower a centralized prior authorization or medication access team to kind of put these three solutions in line in order to address this issue, right? What we're talking about, prescribers knew that they wanted to do it. They knew that they wanted to write a drug that required a PA. The team that gets it said, oh, I got a PA. This came from my doctor, and she really wanted me to do this, so now I'm going to step in and do it right now, and I'm going to do it through the best process I know how, which is an EPA, which we know is the quickest speed to therapy. So when we talk to doctors' offices and where this prior authorization sits and where the PAs are coming from, we see that 61% are coming from the pharmacy, which is really an indication of the patient showing up and being disappointed, right? That's what that stat means, is that the patient said, I couldn't get on therapy, I'm going to have to come back later as we work through this prior authorization barrier. If you look down to the 7%, what a prior authorization, when starting a prior authorization at the point of prescribing by the EHR or EMR, we're seeing 7% is where these are getting started. So ultimately, why bundling real-time benefit check on the front end is the data is showing that we can flip these two, right? We want to drive more prescriber-initiated PAs over the pharmacy-initiated PAs so that we can set better expectations before the patient ever shows up at the pharmacy, and we can make sure that they're guided and coached through this process more proactively than reactively. So if we talk about health system solutions, I've talked a lot about the centralized PA model, which we most commonly see this in some of the thought-leading health systems out there in the industry. And this is how we want to see the process work, and what seems to work best is when the prescriber in the EHR writes the drug that requires a PA, a notification is sent to the prior authorization team when that prescription leaves the EHR and heads to the pharmacy. And then they're going to find the path of least resistance, either for EPA or EFAX, to get the patient on therapy and start working the process directly with the plan or PBM. Meanwhile, they're going to step in and fill the gaps for any issues or challenges that the provider or pharmacy needs while keeping them communicated on the process. So we really want to see this work better together, and we see communication as one of the biggest ways to solve that. As we think about centralizing teams, we want to talk about what they're doing to get the patient on therapy and to get them across the PA. And what we find is these centralized teams are actually doing more than PA. PA is just one indication of an access barrier. So they're looking into patient insurance information. Some of these teams actually work through the pharmacy departments at health systems so they can process their own test claims. They're sending the PAs and aggregating the clinical notes and information in order to make sure that the clinical justification is provided proactively. They're also saying, well, we've resolved the PA issue, but we haven't resolved the affordability issue. So they're working to make sure that they're bringing in financial assistance programs or other foundational things that help the patient get on a therapy and avoid that barrier as well. And they're also working with drug reps, PBMs, and other industry stakeholders to be educated on this process in order to make sure that they're fine-tuning. I mean, if you sat down with somebody who works on these teams, they could teach a PhD on this stuff. It's really amazing to think about the health systems that are fine-tuning this process and getting amazing results and the resources that they're using to get there. And when we talk about working with the providers and how they feel about centralized PA, they definitely agree that it's increasing the workflow and efficiencies, it's reducing the errors in PAs, and it's increasing the PA approval rate, right? So we're doing it faster, we're getting the error submitted, and we're getting the patients approved and on therapy faster than ever. So one health system took the time to do a field study on this process and what it meant to put a centralized PA process in place. And as you can see, the results are quite staggering across the board. We're seeing an increase in approval rates from 68 to 93%, a decrease in denial rates. We're seeing an increase in fill rates. And we're seeing even the labor cost to the health systems by making this a fragmented and disjointed process and putting it in the hands of the experts who live this every day and want to step up and advocate on the patients. It's actually costing the health systems less to pull this process out and have the right people focused on it. But probably the most important stat is we're increasing the time to process by 6.5 days, right? We're getting the patient on therapy faster than ever by putting the right people, the right experts in place to navigate this process especially as PAs become more prevalent and they become more clinically intensive than ever. So thinking about who are the best practices to do a centralized PA, and what are they thinking about, right? So they're thinking about piloting in the primary care or a single specialty, right? Thinking about a certain drug class or certain areas or population centers that you want to address in the area that can't afford their drugs, right? And they can't get on therapy in an expedient fashion. Focusing in that area has allowed people to understand what they need to do within that specialty and then expand from there. And then start moving into more of the acute-based centers and some of the discharge workflows. From a staffing standpoint, we do see that about 50 MPIs per 1 FTE seems to be the effective ratio to navigate this. And we think it's important for both administrative and clinical staff, including nursing, physician's assistants, or even pharmacists are a great asset to the team as we think about combining an administrative process with the clinical documentation and paperwork that it takes to get a patient on therapy. It's also important that we provide the appropriate training. We're talking about a change in workflow, a change in process. You can't just put this out here and expect that resources and processes will change. We need to set up appropriate expectations as to who's doing what, when, and how this is going to work in order to change that process and not have conflicting issues between the care settings and that centralized team. Another barrier that we want to think about is when these solutions really matter the most, right? EPA and real-time benefit check is on these high-cost drugs, right? These are the patients that need more help than anybody, and they really are the ones that are the low-hanging fruit that are getting pulled into these centralized access teams. And how these centralized access teams are helping to advocate for the patients is they're getting access to real-time benefit check. They're making sure that the care team has what they need at the point of prescribing. They have their own platform and tools that they need to be effective. They have the ability to know when a prospective PA needs to be completed. They have a way to engage and share the process with the patient. And they also have a way to make sure that the pharmacy that's doing the dispensing is aware of the work that they're doing and making sure that they can stand behind the decisions and works that were made by this care team. The other thing that's really important is thinking about things as an open network, right? This is how high volume practices, specialty practices and health systems see this process. It is an open network. Anybody who can help increase the speed to therapy, lower the cost of drugs to the patient should have a seat at the table. And it's vitally important that they do, especially when a prescriber knows that there are certain drugs that can get assistance and help downstream or have different access options. If they're not seeing those at the point of prescribing, they're more inclined not to say anything at all because they'll say, just go talk to the other team, right? If I see a high-cost drug, just go talk to the other team, and then they can stand by those decisions and start working through those. So we know that patients want these conversations to take place, especially on these high-cost drugs, but again, we need an open network in order to empower these conversations to take place. So we have to put the patient in the center. We have to make sure that we're thinking about what price transparency can be to them, what options with or without insurances are available, again, to match how the best care settings are doing this process today. And really, when we start thinking about the high deductible plan patients that aren't meeting their deductible, there's a whole market of underinsured and uninsured that need more options and are being asked to be consumers and need more choices in order to fill that void. As we think about prescribing decision support solutions and the benefit information, we want that to be a critical input and a critical choice about meeting their deductible, where they are, what's going on, and will this help them get there, right? We even need to be transparent when they're doing something that won't help them meet their deductible, because in some cases, that's not always beneficial to the patient, and they're not able to leverage all the services that are available through their plan. So we want to think about the patients that are on these high deductible plans, which is continuously increasing, and we want to start talking about the alternative options and really digging into what they mean, right? And that's what the centralized team is doing, is they're telling them what these things mean versus their insurance and how to navigate these options and truly make a decision rather than just sending them down a path. It's joint decision making with the appropriate care team members. And ultimately, we also know that we need to improve the prescriber confidence, right? It's really hard to have a prescriber step in to the patient's shoes and help give guidance on what this means and what they can do on behalf of the patient if they don't believe that all the options and choices are there, especially if they know that they really want to help get the patient on therapy. If they've made a choice, there might be sticker shock, but there are other options and choices that need to be taken care of. And if we don't get this right, and if we don't set appropriate expectations at the first person on the care team who's most trusted, then they will come back and tell that prescriber that it didn't work, and they won't use it ongoing. So again, we have to think about it through their lens. But what's important is that in some of our implementations, we can actually see how often they're checking these drugs and that they're running multiple transactions. And we see about 4 per single visit. They're engaging, they're using, they want this information. And we also know that when we talk about returning the patient pay amount, we compare this against what was surfaced versus how the patient ultimately paid for it, and we have to fine tune that. And when we talk about accuracy, we can't just think about accuracy in regard to that patient's benefit. We have to think about accuracy into how the patient actually accessed it and what their benefits were and what they paid out of pocket on benefit cash or whatever it may be. And that's how we have to measure accuracy, because that's about expectations. So when we think about these teams that are really stepping in and filling this gap around medication access, and coaching the patient, guiding the patient, and matching them how to be successful and be a consumer for the first time in their own healthcare, we need to make sure that they have access to all the information to do it, as we've talked about. But we also need to think more clearly about what this person does. What are their job descriptions? What are their responsibilities? And make sure that the people on the care team have a clear understanding of what that means so that we can set better expectations up front and really drive these processes to make sure that they work and they don't create friction in the process. And we need a strong adoption and commitment from the right people to step in and make it work. And you need communication strategies, you need expectation strategies, and we need to make sure that these technologies and solutions are linked end to end in order to make sure that expectations are set appropriately along the entire way, in order to make sure that the patient knows exactly what they're getting into. So as we went through this presentation today, there were a ton of references that we pulled forward that will be available to you guys as we're recording this webinar. I would encourage you to dig in, make sure you understand what this data means and how you could use some of these practices going forward. And I would also say that we would be available to anybody who would want to have any further discussions about what these mean. So with that being said, I appreciate you guys taking the time to kind of listen through my journey over the last couple of years into price transparency and medication access issues. So thank you.
Thank you, Dustin, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. We've already received a ton of great questions. The first one is, what is the industry's best data response for real-time benefit checks? So out of 100 prescriptions, how many RTBC requests return no information?
That's a really good question. And I think that's how I'd like to see the industry think about this. We want to think about, so if there were 100 prescriptions, those are 100 patients, right? So let's stop thinking more about the how we're matching up the pipes and making it work. And let's just think about a prescription as a patient, right? How many patients can you serve? So if 12% of the U.S. is uninsured and there's a certain amount that's underinsured, I think I'd have to look up the stat, but it's probably in the 30 to 40. Then how are they being served by these solutions? And I think it's critical to think about it that way. So I actually appreciate the question, right? So we do see that some solutions are matching on the front end to say, can I route to here, and kind of measuring their response rate against that. I like to think it as a gross response rate, which is 100 prescriptions went out, how many did you price? I think some of the best solutions we're seeing in the industry are around 4 out of every 5 prescriptions are actually getting priced. And again, I think that some of those solutions are looking outside of some of the traditional models in order to get to that response rate. Again, because the plans are not opting in through their PBMs to activate this technology. So we have to look at alternative ways to increase that. Great question.
Thanks for that. The next question is, what does Cover My Meds cost the pharmacy or provider?
That's a good question. So for the provider, the cost is absolutely free. If you talk about from the Cover My Meds solution, we do bring in the pharmacy as a data source, and they do pay to do that. So that's one of the ways that we personally increase our response rate, and they pay for that to increase the clean scripts that are walking in the door, to avoid them taking on the burden of addressing those issues. So again, free to the provider, and a cost to the pharmacy that we could talk about probably more offline, depending on what you're trying to do with that service and what your scale is on that.
Thanks for clarifying this. The next question is, what should I be asking as I evaluate a solution for my physician care setting?
Yeah, I think that's a good question. I'd probably harken it back to the first question I got, which is, first of all, I'd like to see the industry stop thinking about, do you have this PBM or do you have this PBM? And I'd like to start us thinking about in terms of plans. And I'd like to start thinking about the gross response rate based upon prescriptions leaving the EHR. I think that is the best thing we can do to drive prescriber trust, impact, and really get these solutions to work. If we're not responding on the vast majority of prescriptions, that we're falling back to F&B and we're missing the response rate, right? I would also think about, when we talk about EPA, what solutions are available for centralized PA? Do you have options and choices that allow me to empower that process? And does it go beyond just benefit information? Does it include anything that can help lower the cost to the patient or address the barriers that a patient may see? And thinking more broadly around benefit. I think benefit, again, is critical, but we need to think about this holistically, both from how a patient can truly access, and then we also need to think about it from how many prescriptions and patients can we impact at an aggregate within a care setting.
Great, thank you. The next question is, how do I know if my EHR has an RTBC solution available?
Yeah, that's actually a good question. It varies. So some EHRs will have the health system or the care setting make a choice as to, do they want to use a real-time benefit check or EPA solution. Some will just make it widely available if you're on a current version. And others still may not have a solution at all on one end or the other. The easiest thing to do is really just contact your EHR. We have resources available too. I think there's a industry scorecard that Cover My Meds puts out that kind of talks a little bit about what major EHRs are using. That might be a good resource, but really the best thing to do is that most EHRs are kind of configuring and setting this up based upon what they think is best for their practices and care settings, and I'd probably start with them.
Great, thanks for that informative response. This next audience member asks, how are providers navigating a medical versus pharmacy benefit determination? They say, I'm asked what is least expensive for the patient and don't always know how to answer.
That is an awesome question. I don't think that there's an easy way to answer that comparison. I know that some PBMs and some payers are making this available via API, but it's still pretty new. And I think it's going to be the future evolution of real-time benefit check, is that will include some of that decision tree for some of the specialty or high-cost drugs. I would say that's even less widely available than some of the stuff we've talked about. I know that some of the best health systems that we work on, say for oncology or some of these other therapeutic areas where they have to make that decision a lot, they're going to have their own pharmacy in-house, and they're going to have a care team help make that determination, right? So we know that if it's going to be a determination between a medical and a prescription benefit, then it's probably a high-cost drug. So typically, I think prescribers are opting out of those discussions, and they're sending them to somebody else in the department that can do the investigative work on one of those centralized teams to come up with a patient-centered recommendation. So I'd say that the industry is racing to solve this problem right now, but for the most part, it's going to be the centralized teams that are helping to make that determination, because it takes a little bit of investigation.
Great, thank you. This next audience member asks, how does a care team access the technology? They write, I work in transplant and lots of Medicare Advantage plans. Would this be a good solution for us?
That's a good question. So, some of the things that we see is that we do want to fit some of this into the EHR. I think that's the ultimate goal, is to make sure it's linked to that. But it's not all these solutions, especially if we talk about, a transplant work. If we're talking about medication access to transplant medications, that's one thing. If you're talking about other prior authorizations, medical prior authorizations, that's a whole different process. So for complicated things like that, I think that, you might find yourself using a couple of different solutions or going to that centralized care team to kind of help fill the gaps. But I do know that our offerings works with with the Medicare Advantage plans, and that's something that we take a lot of pride in. But again, I think that without knowing the intent behind the transplant versus you're looking for prescription or medical, I think that's a challenging one, and I do know that even transplant medications can be pretty complex to navigate. And we want to think about leaning on those centralized teams and giving them the tools they need in the short term.
Great, thanks for that. This next question is, are there any technology solutions that Cover My Meds provides or can recommend to assist healthcare organizations to address the issue of low-income, uninsured patients and access to affordable medication?
Yeah, that's a good question. So one of the things that we are personally working on is incorporating cash discount offers into our solution. And we think that that's a critical piece of the equation for that population, but we want to do it in a smart way, right? So if we see that a cash discount is not better than a benefit, then we shouldn't show it. That's not the correct guidance. If we see that patients met their deductible, then we shouldn't show that. So we are working it into our strategy, but we're really trying to work it in an inclusive way as part of the decision-making process to, again, clean up the prescribing screens, right? It doesn't make sense to show cash discount to a busy prescriber if the benefit is a better option. So we are working on that as we speak. More to come actually at upcoming HIMSS on that.
Thank you so much for that. This next audience member asks, have you seen this used in a hospital setting for discharges?
We do. We see it used in discharge nurses, discharge workflows and discharge nurses a lot. I would say that I don't hear a lot that's particularly fit into that model at scale right now. But it's an area that we kind of feel is underserved and something that we'd like to see addressed, and we do think we need to fine tune some of these solutions, particularly for that discharge workflow.
Great, thank you. This next audience member asks, you described a baseline staffing of 50 NPIs per 1 FTE. What is the time frame of completing those NPIs? Is that per week?
So I think when we talk, I want to make sure we're using the right terms just to make sure that we're clear here. So an NPI, we basically would mean a prescriber in this standpoint. So if there are 50 prescribers, we want 1 FTE. If we talk about completing those PAs, which I think is what we're talking about, we were down to like a half a day on getting the PAs through. Again, you can ask another question if you want, but I'm not quite sure I'm understanding the question fully. But again, feel free to follow up with me afterwards. I just want to make sure we're using the right kind of acronyms, which is typically a problem in healthcare. So make sure we're using the right acronyms to describe that process.
Okay, great. And it looks like we have time for one more question, which is, how does prescription price transparency work if a plan is not involved in the pricing?
It would depend on who your vendor is, right? So if the plan is not involved in real-time benefit check, or they haven't opted in through a solution, most commonly that's going to fall back to formulary and benefit, right? Kind of the old school solution that's not patient or really plan specific. And again, I think we would find that to be a continued disservice to the industry and the progress we're trying to make. One of the things that we try to do here is we actually would call the pharmacy when we can't get a price from the plan, so that the pharmacy can price it against the plan. It's a little bit of it returns different data, but we find that it increases the response rate and it increases the patient served. And it is an accurate indication of that patient's cost at that pharmacy against their deductible. So we rely on that pretty heavily to fill the gaps of plans that aren't available.
Great, thank you so much. So that is all the time we have for today. Dustin, do you have any final thoughts?
No, I appreciate the questions. You guys kind of knocked me back on a few of these. These are really thought out. And what I would say is that kudos. It gives me confidence that maybe we're not alone out here trying to solve this issue. And really excited about the progress that's been made in the industry from all the vendors and partners and care settings that are participating in these solutions. It's really it's a move forward, and it's going to help drive to consumerism and better choices and making sure we're matching things to the patient, which gets me excited every day. I would love to see us increase the data sharing and collaboration of information so that we can kind of fine tune these solutions and increase the response rates and make sure that the right choices are being presented to the patients. So I'm excited for that to be the next evolution of what we do next, is increasing the collaboration and data sharing to maximize what we can really do with these offerings.
Yeah, that's a great note to end on. So that will conclude today's webinar. I want to thank Dustin for his excellent presentation and Cover My Meds for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.